This is LiveWell Talk on colon cancer screening. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. Excluding skin cancers, colorectal cancer is the third most commonly diagnosed cancer in the United States. Joining me today is Dr. Douglas Purdy, gastroenterologist with St. Luke's Gastroenterology, to discuss colon cancer signs, symptoms, and the importance of screening and how to reduce your risk for cancer. Dr. Purdy, welcome.
Thanks for having me, Dustin.
Big shoes to fill.
Yeah.
Our retired colleague, Dean Abramson. So, we'll compare, these two broadcasts. We'll see how they do.
Don't compare me to Dean, please.
I think you're going to do great. So, I know we talked a little bit prior to the podcast, and we make the presumption, and it's a safe presumption, that the listeners are pretty sophisticated and they understand what colon cancer is. But could you just kind of give us just a brief overview? What is colon cancer and how does it start?
Sure. So colon cancer is a malignant tumor of the lower GI tract. We're talking about the colon. The lower 8 inches or so of the colon we call the rectum. So sometimes you'll hear people refer to colon cancer as colorectal cancer, same thing. And it starts as a small benign polyp, a precancerous polyp, which could be, a millimeter or so in size. And over years, that can slowly develop and grow and turn into a colon cancer.
And in the lay public, as well as in the medical literature, people are presenting younger and younger with colon cancer. Isn't that true?
That's correct. Colon cancer, we've always thought of it as being a disease of older people, but over the past several years, it's been noticed that people younger than age 50 are developing colon cancer a lot more often. The people over 50, the incidence of colon cancer over 50 over the past several years has been decreasing about 2 to 3% a year. But over that same period of time, patients younger than 50, especially the 45 to 50-year-old age group, it's been increasing about 2% per year.
I think the hesitation to get the screening colonoscopy is part of it. Part of it, people are just so busy. I mean, I didn't get my screening colonoscopy till this year. I'm 53. I knew I needed it at 50. I just didn't get it done. And I knew it was important. I wasn't afraid of it, just logistically, that's how things go. And so we really want to stress, that the screening colonoscopy may be a day out of your life, but it could extend your life. And it's the inconvenience of colonoscopy a lot better than having surgery and chemotherapy for colon cancer, right?
Exactly.
So, but I think, you go from that being in your 30s and your 40s and you really don't have chronic medical problems, and then you start to get in your 50s and 60s, and there's a transition period in there where you denial maybe is the best way to describe it. So what are some motivated interviewing tactics or when you meet with people to talk to a younger person that this is why you need a colonoscopy? What's some of your strategies?
Well, as they get closer to 45, in their early 40s, 50, closer to 45, just tell them that the risk of colon cancer increases with age. And you're much better off to get a screening exam, like a screening colonoscopy, where we can find these polyps in very early stages when they're benign, precancerous, but yet still benign, and we can remove those and totally prevent colon cancer. Colonoscopies and removing polyps is really the only way to prevent colon cancer.
And it's one of the few screening tests we have. Other than bronchoscopy, and we don't really do bronchoscopy for screening. It's one of the few screening tests is also screening, but also therapeutic and diagnostic at the same time, right? You could see the precancerous polyp, remove it. So if you kind of war game this out a little bit, actually the colonoscopy probably is more efficient use of the patient's time than would be other imaging studies that lead to more and more testing.
Right. There are other screening studies that you can do for colon cancer. You can do a simple test that tests for occult blood in the stool. It's called a FIT test. That'll pick up, I believe, somewhere like around maybe 72, 74% of colon cancers, but we'll miss a a large percentage of significant polyps that could turn to colon cancer, maybe in anywhere from 1 to 3 years. So there's just screening for occult blood. There's the Cologuard, which I'm sure everybody's heard. It's on TV all the time.
They have the cute little commercials.
Yeah, exactly. That screen that looks at two main things: occult blood or hidden blood in the stool, as well as altered DNA in the stool, which would suggest maybe a colon cancer. And they say that's maybe 92% effective in finding colon cancers, but only about like 42% effective in finding large polyps of the colon. So again, missing a significant number of large polyps that can turn to colon cancer.
Yeah, I think that's if there's one item that people take away from this podcast, I hope they understand that the stool test, they hopefully find the cancer early on, but they don't prevent cancer. Where the colonoscopy, if you have that precancerous polyp removed, you have prevented cancer.
Right. If you have one of these other tests, a FIT test or a Cologuard, and it's positive, then you really should have a colonoscopy to have the colon actually looked at and examined, and then they can see, are there polyps in there that need to be removed, and by removing those polyps, that's what prevents the colon cancer. And then if there is a mass or a tumor, then that would be biopsied to make the official diagnosis of colon cancer or not.
And that comes back in a couple days after you do the biopsy? How
yeah,
long
they're usually pretty good. I mean, you can request it for a 24-hour read and call, but on average, the pathologists are really good here at St. Luke's, and most of our pathology results are coming back in almost 24 hours anyway.
Yeah, that's reassuring to the patient.
Yeah.
No matter how much you might say this looks precancerous, that it's important to the patient for obvious reasons. So, how, in your experience, 30 years in practice?
Yeah, I started in 94, so we're going on 29 years. Yeah, 29 years this summer.
Coming up on 30 here, not too long off. How do people with colon cancer usually present?
So it can really vary. It could be somebody has a change in their bowel habits. They've been regular all their life, and all of a sudden something's changed one way or another that gets them to see their doctor. Rectal bleeding is a big one. Abdominal pain. A lot of times they'll have no symptoms other than, say, iron deficiency anemia. When a patient gets referred to me for iron deficiency and anemia, an adult patient, usually I tell them the number one diagnosis on my list till proven otherwise is colon cancer.
Yeah.
So, really iron deficiency anemia is a big one. We want to check the colon. But then we also have to remember, a fair number of people, especially with the earlier stages of colon cancer, have no symptoms at all. And that's where screening colonoscopy plays a big role in picking those patients up at the early stage of colon cancer rather than waiting till it turns more advanced maybe and starts causing symptoms.
Yeah, early on over my career, which is 1990. What year did you start?
I started here in 94.
94. I started in 96 in Grinnell. So, but that, we've come a long way with the survivability of colon cancer has improved. I mean, it's pretty dramatic, really.
Right.
But still, the ability to prevent something, I think, is just the phenomenal take-home point here, that you have the opportunity. You're at high risk because you have a Western diet, right?
Right. Yeah.
And you have risk factors. You live in a first world society, so you have all the luxuries that go along with that, but you also have the risks that go along with that. And this is an opportunity to actually prevent it. I just find it amazing. Part of it might be I had mine this fall, precancerous polyps taken off. A colon cancer was prevented with that procedure.
Exactly. Yeah, you talked about the risk factors. I just briefly mentioned those, but we kind of group those into what we call modifiable and non-modifiable. The non-modifiable risk factors, there's not much you can do about it. It would be, age. As you get older, it gets a little more risk. If you have type 2 diabetes, that puts you at a little higher risk. Blacks are higher risk for colon polyps, colon cancer. If you have a family history of colon polyps or colon cancer, especially first-degree relative, 60 or younger, or if you have 2 first-degree relatives of any age, that puts you at higher risk. And we usually start screening well before age 45. If you yourself have a history of polyps, well, that puts you at risk for more polyps and even colon cancer in the future. So that's something you need to have your colon, checked regularly. So those are things, what we call the non-modifiable. And then there's what we call modifiable risk factors. That would be things like, they say that sedentary lifestyle increases your risk of colon cancer. Obesity increases your risk. Diets that are inadequate in dietary fiber, diets that are high in red meats, like beef, pork, lamb, liver, or diets that are high in processed meats like hot dogs, certain lunch meats. Smoking is a risk factor, and moderate to heavy alcohol use is also a risk factor for colon cancer. So those are all things, that the patient can kind of try to do something about, to try to decrease their risk of colon cancer.
Ulcerative colitis, Crohn's. We didn't even mention that.
Didn't mention that, but that's a good point. Personal history of inflammatory bowel disease, especially ulcerative colitis, if it involves a greater extent of your colon, if it involves most of the colon, that puts you at higher risk, especially after you've had it for several years. We usually tell a patient once they've had ulcerative colitis that involves most of their colon for 8 years or more, then we usually start doing surveillance colonoscopies about every year or 2.
That's another, maybe we should mention, if you have inflammatory bowel disease, FIT testing is not for you.
No, it's not at all.
And so just to stress to patients that if you have that, you need to be, hopefully they're under the care of a gastroenterologist and they're being seen regularly, which that would they know. Well, Doug, I think you are doing a number 1 job in a number 2 business. Isn't that the saying?
Thank you.
Yeah, you're
doing my best.
Yeah. But what got you into gastroenterology?
It's during my internal medicine, during med school and internal medicine, we were exposed to it a little bit. And I just thought it was very interesting because it's just got such a vast, diverse amount of diseases in it, and patients that you could see, the luminal GI tract, the liver, the pancreas, the bile ducts, and we are exposed to patients of all ages. We start seeing patients about age 18 all the way up, through their life, and it's a specialty where I think you can really help patients. They come in with certain problems. They can't swallow food. They're getting food stuck. You do an upper scope, you diagnose a stricture, you stretch it open, put them on medication for acid reflux, and they feel 100% better. So it's, I think you can really, as a gastroenterologist, you can really make an impact in people's lives. Some people with, like, say, inflammatory bowel disease, you'll see them maybe for your whole career because they're patients that, usually come back, every year and follow up with you. So it's just been a very, I think, rewarding career.
Good for you. Yeah, you guys get pretty possessive with those inflammatory bowel disease patients because you've just seen them for so long. And that's always good to be part of that team. Well, Doug, Dean's got some competition. You did a great job. I'm glad you were here today.
Thanks.
Once again, this is Dr. Douglas Purdy. He is a gastroenterologist with St. Luke's Gastroenterology. To learn more about screening, visit unitypoint.org/colon. If you've been diagnosed with colon cancer or any type of cancer, call the Nassif Community Cancer Center at 319-558-4876 or visit communitycancercenter.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.